Welcome to the deep dive. Today we're tackling a really significant issue. It's something that can linger long after a blood clot in the leg. It's called Post-Thrombotic Syndrome, or PTS.
That's right.
We've got some deep reading lined up from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition, actually.
Mhm.
And we're going to try and unpack, the natural progression of PTS, what's really happening under the hood, and what sets it all in motion.
Yeah, our goal really is to give you a solid understanding of PTS.
Hmm?
What exactly is it? Who's most at risk? And what are the biological processes driving it?
Right.
We also want to shed some light on the long-term consequences it can have on someone's life. We're here to pull out the crucial pieces of information for you.
Okay, so let's start with the basics then. What is deep vein thrombosis? DVT. We hear that term a lot.
So simply put, it's a blood clot forming in a deep vein, usually down in the legs.
Okay.
And what's interesting is maybe half the time these clots just resolve on their own. But in about, say, 20% of cases, they can actually extend further up the leg. And that's when PTS becomes, a real possibility.
A real concern. Yeah.
Definitely. Post-thrombotic syndrome can affect a pretty significant number of people who've had a DVT, and their lower limb estimates range from maybe 20% up to 50%.
Wow, that's a wide range, but still high.
It is. And it typically shows up maybe a few months, sometimes a year or even 2 years after the initial clot.
And the effects, they vary quite a bit.
They really do. It can be anything from just persistent swelling in the leg, which is bothersome enough,
Sure.
to much more serious things like ongoing pain and even the development of skin ulcers, which can be very difficult to heal.
Okay, so who is more likely to actually develop PTS? Let's delve into what the research tells us about, the causes and how common it actually is.
Well, DVT itself is more common than many people realize. It affects maybe up to 3 in every 1,000 people each year.
That's quite a few.
It is. And while things like varicose veins, what we call primary chronic venous disorders, are more common overall, DVT is a major cause of secondary chronic venous disorders. It plays a role in something like 18% to 28% of limbs affected by CVD.
Hmm. And those skin changes you mentioned, they don't happen right away.
No, that's a key point. They tend to appear gradually. You might see them at about 4% of limbs after 1 year, but that number jumps significantly, maybe to around 25% after 5 years.
Right. Now, here's something that really jumped out at me from the reading. The impact of getting another DVT in the same leg.
Oh, absolutely. That's probably the most significant factor increasing the chances of developing PTS.
Really?
Yes. Studies suggest it can increase the risk up to 6 times. And it also makes the progression of that underlying chronic venous disease much more likely, a relative risk of about 4.4 for progression.
And how often does that happen, getting another DVT?
Well, the numbers show it recurs in about 17% of people within 2 years. That climbs to 24% within 5 years and around 30% within 8 years. So it's not insignificant.
No, definitely not. And for those unlucky enough to have that recurrence, the chances of severe PTS sound quite worrying.
They can be, yeah. Severe PTS, the kind that includes those really difficult ulcers, is estimated to affect maybe 5% to 10% of patients who have a recurrent DVT, especially one that's higher up in the leg, like in the thigh or pelvis.
Hmm.
And looking long-term, the cumulative risk of developing an ulcer due to PTS is around 5% over 10 years, but that could potentially increase even further out, maybe up to 20 years.
So, okay, beyond just having another clot, what other factors might make someone more susceptible to getting PTS?
Well, several things seem to come into play. If the initial DVT was very extensive, meaning it involved a large part of the leg's veins,
That makes sense.
that increases the risk. Also, unfortunately, not getting enough or maybe inconsistent anticoagulation treatment can contribute.
Okay.
But what's particularly interesting and something researchers are focusing on more is how much the vein remains blocked after the DVT. It seems that if the clot doesn't fully clear, leaving what we call a persistent obstruction,
Uh-huh.
that poses a greater risk for PTS than just having leaky valves in the veins, which is called reflux.
Right, so the blockage itself is a major issue.
It appears so. However, if you have both the veins are still partly blocked and the valves aren't working properly, the reflux part.
Double trouble.
Exactly. Especially if that involves both the surface and the deep veins, maybe the whole leg, that's when we tend to see the most significant symptoms and those skin changes. It really looks like the combination of obstruction and reflux is more damaging than either one on its own.
That makes intuitive sense, I suppose. It's like having, a traffic jam and broken traffic lights all at once. And the data seems to back that up.
It does. There was one study that followed people after their very first DVT. It found almost 23% developed PTS within 2 years, and that went up to 28% after 5 years.
Okay.
And crucially, that recurrent DVT in the same leg was a major driver, increasing the risk something like sixfold. Also, where the initial DVT is located and how much of the vein system it affects, that makes a big difference too. If the DVT affects multiple segments of the leg, you see much higher rates of symptoms, skin damage, and even ulcers compared to a DVT that's just in one area.
And this isn't just about the physical impact on the person, is it? I imagine there are broader consequences economically and socially.
Absolutely.
Mm.
Severe PTS, especially when it leads to those venous leg ulcers, can really devastate someone's quality of life.
Yeah.
People often report it being worse in terms of physical limitations than conditions like, say, osteoarthritis or chronic lung disease.
That's saying something.
It is, and the financial costs are huge. Just in the U.S., the annual cost of treating venous leg ulcers alone is estimated at nearly $15 billion.
Alien. Wow.
Yes. And that doesn't even count the lost workdays,
Mm.
which are estimated at maybe 2 million annually just because of these ulcers. It's a massive burden.
Okay, let's shift gears a bit now. Let's talk about what's happening at a more fundamental level, the cells, the molecules involved in PTS development.
Right, this is where it gets pretty intricate. The initial DVT really sets off a complex chain reaction.
Mm-hmm.
It's not just a physical clot sitting there. You get injury to the wall of the vein itself.
Mm-hmm.
You often have incomplete clearing of the clot, that persistent obstruction we mentioned,
Yeah.
and damage to those delicate valves inside the vein. All of this adds up to sustained high pressure in the veins when someone is upright, standing, or walking. We call that ambulatory venous hypertension.
Okay.
And the DVT itself triggers a really significant inflammatory state and also a pro-clotting state in the body.
So it's like the body's own response to the clot kind of creates the conditions for longer-term problems down the line.
That's a great way to put it. Exactly.
Yeah.
The cells lining the inside of the endothelium, they get damaged. They start pumping out substances like tissue factor and PII-1, which promotes clotting and inhibits clot breakdown. And there's a release of von Willebrand factor and things called selectins. These molecules basically amplify the clotting process. They attract immune cells to the area, and they lead to the release of these tiny things called microparticles.
Microparticles. Those sound important. What do they do?
They really are key players. They're like tiny little sacs, almost like bubbles, shed from platelets, white blood cells, and those endothelial cells lining the vessel.
Okay.
And they actually promote more thrombosis, more clotting. They carry tissue factor on their surface, they inhibit the body's natural clot-busting system, fibrinolysis, and they express PAI-1.
So they're fueling the fire, basically.
Pretty much. And another molecule, P-selectin, seems to help sort of localize these pro-clotting microparticles in areas where the blood flow might be a bit sluggish, like behind the clot, further driving the problem. Think of them as little messengers spreading the keep clotting signal.
So it can become a bit of a vicious cycle then.
Precisely. At the molecular level, it's this whole network of interactions driving things forward. You've got activation of adhesion molecules like those selectins, involvement of immune cells, monocytes, macrophages, activation of things called toll-like receptors, which are like the immune system's alarm bells, the ongoing release of those microparticles, plus signaling molecules like chemokines and cytokines, enzymes that break down tissue called matrix metalloproteinases, and growth factors. All these things together influence how well the body resolves the clot versus how much persistent inflammation and damage leads to scarring or fibrosis in the vein wall.
And this deeper understanding of these molecular players, that must be opening up possibilities for new treatments.
It absolutely is. For instance, there have been studies in animal models looking at blocking P and E-selectin, and they found that doing so can significantly improve how well the clot breaks down recanalization and reduce the inflammation and scarring in the veins, importantly, without increasing bleeding risk.
That's crucial.
Very crucial. And there's even been some early research in humans using an E-selectin inhibitor that showed some improvement in certain patients with venous thrombosis. So yes, this is definitely a promising area for developing future therapies aimed at preventing or mitigating PTS.
Okay, let's move on then to how PTS actually develops over time, its natural history, and sort of the underlying pathophysiology. It seems the initial thinking really zeroed in on those damaged vein valves.
That's right. Yeah, the earlier research often used techniques like Doppler ultrasound to measure how quickly the veins refilled with blood after you squeeze the calf, for example.
Okay.
The idea was if the valves were leaky, incompetent, the blood would rush back down quickly. So these faster refilling times were linked to more severe PTS. The focus was really heavily on that venous valvular insufficiency.
But it sounds like from what you said earlier, the picture is maybe a bit more complicated than just leaky valves alone.
Absolutely. More recent findings have really underscored the importance of both the persistent blockage, the obstruction, and the damage to the valves, the reflux.
Right.
It seems to be that combination blood flowing backwards in both the superficial near-surface veins and the deep veins, especially if it affects the whole leg or even just below the knee, that's now recognized as a major driver of severe symptoms and those problematic skin changes. There was one study looking specifically at patients who already had PTS, and it found that the vast majority, like 65% of them, had both reflux and obstruction in their deep veins.
So it wasn't just one or the other for most people.
No. Obstruction alone was only present in about 15%, reflux alone in maybe 18%, and only a tiny fraction, like 3%, had essentially normal findings on the tests. And that skin discoloration, hyperpigmentation, was strongly linked to having both reflux and obstruction together.
Okay, that's quite clear. So what did those early studies, the ones tracking DVT over time, tell us about how things progress?
Well, those early natural history studies track things like, how well the clot dissolved or leased, whether reflux developed in the veins over time, and they often use leg swelling, edema, as a kind of marker for PTS. And they found that if the initial clot cleared more quickly, what we call early recanalization, the valves tended to function better down the line.
Makes sense.
Interestingly, though, swelling in the very early stages, like the first week to a month after the DVT, seemed more connected to whether there was still some clot left, the residual occlusion. Whereas swelling that persisted later on seemed more related to those leaky valves kicking in.
And the speed then at which that initial clot breaks down seems really critical for the long-term health of those valves.
It really does seem to be. The faster the vein manages to clear itself out, the better the chance of preserving the integrity of those valves. Studies have actually measured this and found that the time it takes for a blocked segment of vein to reopen is significantly longer, maybe 2 to 7 times longer, in those segments that later go on to develop reflux compared to segments that don't.
Wow.
And what's also interesting is that reflux, that leakiness, can actually appear even when there's just a little bit of clot left behind. It suggests the valves might get damaged quite early in the process.
So clearing the clot early helps, but it's not the whole story for valve function.
Exactly. While early recanalization is definitely beneficial, it's also clear that other factors must be involved in why some valves become incompetent and others don't, even if the clot clears reasonably well.
Okay. We've talked about blockage and leaky valves separately and together. What does the research specifically tell us about the impact of just having that persistent blockage, that venous outflow obstruction?
Yeah, research focusing specifically on venous outflow obstruction has pretty much confirmed what we suspected.
Right.
Having both reflux and obstruction leads to much more severe signs and symptoms of chronic venous disease.
Right.
And importantly, it leads to a significantly higher risk of developing those venous leg ulcers compared to having just an obstruction on its own. The risk was something like 24% with the combination versus only 3% with just obstruction in one study.
That's a huge difference. And you mentioned earlier that where the DVT happens in the leg matters too.
Absolutely. A DVT that affects multiple levels, so maybe the calf and the thigh, especially if it involves the iliac vein up in the pelvis, that's strongly linked to a specific symptom called venous claudication. That's leg pain that comes on with exercise, like walking, because the blood can't get out effectively.
Okay.
And that multi-level DVT, particularly with iliac involvement, is also linked to more advanced PTS, more skin damage, and ulcers. Again, limbs that have both reflux and obstruction are much more likely to develop these skin problems.
And even specific veins like the one behind the knee.
Yes, the popliteal vein. Poor function there, whether it's blocked or leaky, significantly increases the odds of developing PTS, something like more than 3.5 times higher risk.
Wow.
And having a blockage that affects multiple segments, including the popliteal vein, also raises the risk. Even down in the calf, having clots in multiple calf veins seems to be worse than just in a single one. And if you have a calf vein DVT plus a DVT higher up, that combination also bumps up the PTS risk.
It really sounds like venous disease that starts with a DVT might progress to the more serious stages faster than, say, problems arising just from varicose veins.
That's a key observation from the research. Studies comparing the two show that chronic venous disease progresses much more quickly in patients who've had a DVT compared to those with primary venous disease. At a 5-year follow-up point, for instance, Skin damage was found to be 4 times more common in the DVT group compared to the primary CVD group.
4 times. Wow.
Yeah. And again, looking at risk factors within that DVT group, having blockages in both the proximal upper leg pelvis and distal lower leg veins, and having that combination of reflux with obstruction were significant predictors that someone would go on to develop PTS.
And it's not just something that affects older people over many decades, right? This can happen relatively quickly.
No, absolutely not. Research following patients after their very first DVT shows significant rates of skin damage appearing within just 2 to 5 years.
That's quite soon.
It is. And interestingly, perhaps counterintuitively, some studies have suggested that men might actually be more prone to developing the more advanced signs of PTS, like the skin discoloration and the ulceration.
Huh. Interesting. So thinking about the body's own processes, what about its ability to break down clots? Does that influence the risk of PTS?
It seems to. Research has shown that the ability of the body to naturally reopen that blocked vein after a DVT recanalization process is actually worse in people who had higher levels of things called prothrombin fragments right at the start.
What do those indicate?
They basically indicate that the clotting system was highly activated when the DVT formed.
Yeah.
Recanalization is also worse in people with higher levels of substances that inhibit fibrinolysis. That's the body's natural clot-dissolving process.
Okay.
And it's also worth noting that D-dimer, which is a marker doctors often measure, it's a breakdown product of clots
Right.
that can actually stay elevated in the blood for a long time after the initial DVT, suggesting ongoing low-level clot turnover or inflammation.
We keep coming back to this idea of high pressure in the veins, venous hypertension. It really sounds like that's the central mechanism driving PTS development.
It truly is. You can think of it as the final common pathway for a lot of these issues. In PTS, you get this sustained high pressure in the veins, particularly during walking, the ambulatory venous hypertension we mentioned.
Yeah.
And that's caused by either that persistent blockage, the obstruction, or those leaky valves, the insufficiency, or often both. This sustained high pressure leads to changes in the structure of the vein walls themselves. It promotes chronic inflammation in the surrounding tissues, and ultimately it causes damage to the skin and the subcutaneous tissues just beneath it.
So walk us through that sequence again after the DVT happened.
Okay, so first you have the DVT, the blockage, and the immediate inflammation. Then the body starts trying to clear the clot, the recanalization process begins.
Right.
But if this clearing process is incomplete, or if the valves within the vein get damaged during the initial clot or the inflammation, that leads to that persistent high venous pressure. This high pressure then impairs the function of the calf muscle pump. The muscles in your calf are crucial for squeezing blood back up towards the heart when you walk.
Okay.
If that pump isn't working well because of the high pressure, it can actually lead to further damage to the valves, creating this kind of vicious cycle. And while the body might try to compensate by developing new, smaller veins called collaterals to bypass the blockage, these often aren't enough to fully normalize the pressure.
And I assume doctors have ways to actually measure how severe someone's PTS is to track this.
Yes, definitely. There are several clinical scoring systems used to assess the severity. The Villalta scale is probably the most widely used and validated one.
Okay.
It looks at both the symptoms the patient reports, like pain, heaviness, swelling, and also objective signs the doctor can see, like redness, skin discoloration, or ulcers.
And does that score tell you anything about the future?
It does seem to. Higher scores on the Villalta scale correlate pretty well with a worse quality of life for the patient. And importantly, some research suggests that having a higher score even just 1 month after the initial DVT is a strong predictor of having worse long-term outcomes, more severe PTS down the road.
Okay.
There are other scales too, like the Ginsburg measure, which focuses more just on persistent pain and swelling, and the Brange scale, which includes measuring leg circumference. But Villalta is the most common.
Got it. And finally, let's just circle back one more time to where that initial DVT occurred. It sounds like a clot higher up in the leg is particularly problematic for PTS risk.
Absolutely. A DVT that occurs in the proximal veins, so the iliac veins in the pelvis and the femoral veins in the thigh, what we call iliofemoral DVT, that is consistently shown to be a major risk factor for developing PTS.
How much does it increase the risk?
Studies have shown quite a range, but it can increase the risk anywhere from 40% up to potentially 600%, so sixfold, compared to a DVT lower down in the leg.
Wow, that's a huge range, but consistently higher.
Yes. And an iliofemoral DVT is also a strong predictor of developing that venous claudication we talked about, the leg pain with walking.
Right.
Other factors that seem associated with higher post-thrombotic scores in some studies include older age, Having a higher body mass index, BMI, and perhaps surprisingly female sex has also been identified as a risk factor in some, though not all, studies.
And what about trying to dissolve the clot very early on? Does that help prevent PTS?
Well, there's certainly the hypothesis that actively trying to dissolve the thrombus early, using clot-busting drugs or procedures, might help prevent PTS by clearing the vein faster and maybe preserving valve function.
Mm-hmm.
But honestly, the definitive data on whether this consistently works and is safe for most patients is still somewhat lacking. More research is ongoing in that area.
Okay. So to wrap up our deep dive today, what are the main takeaways?
Well, I think the key points are that post-thrombotic syndrome, PTS, is a really frequent and potentially very debilitating long-term consequence of having a deep vein thrombosis. It places a significant burden on individuals, really impacting quality of life, and it also comes with substantial healthcare costs.
Hmm.
The major factors that really ramp up the risk of getting PTS include, number one, having another DVT in the same leg recurrence.
Okay.
Number two, the initial DVT being extensive and located higher up, particularly involving those iliofemoral veins. And number three, having that damaging combination of both leaky vein valves, the reflux, and a persistent blockage in the veins, the obstruction.
Got it.
Achieving early and complete clearing of that initial blood clot seems crucial for preserving valve function and, potentially at least, reducing the likelihood of developing PTS later on. And remember, the underlying processes involve this really complex interplay of the initial clot, the body's inflammatory response, and
Yeah.
subsequent damage to the vein wall, all ultimately leading to that sustained high pressure in the veins.
Okay. And that brings us, as always, to our final thought for you, the listener, to consider. Given just how significant the impact of PTS can be, what do you think are the most promising directions for intervening early and managing this condition better in the long term? How can we really lessen its effects? And maybe even more fundamentally, how can our growing understanding of all those intricate molecular mechanisms we touched on actually be translated into safer and more effective strategies to prevent PTS from developing in the first place? Some really important questions there to think about. Thanks for joining us for this deep dive.